The next presentation will be treatment of center-involved diabetic macular edema with better vision, results from Protocol V by the incomparable Jennifer Sun.
Thank you very much. It's a pleasure to be here today to present this data on behalf of the DRCR Retina Network. Here are our financial disclosures. Regeneron did provide the aflibercept for the study, as well as funds to defray the site's clinical site costs, and here are my financial disclosures for personally. So multiple phase 3 studies have established that anti-VEGF is first-line therapy for eyes with visual impairment from diabetic macular edema. But what these studies all have in common is that they've all enrolled eyes with vision of 20/32 or worse. And until this year, anti-VEGF had not been evaluated formally in eyes that have center-involved DME with good vision, 20/25 or better. Here's an example of the eye on the right, where you see clear center-involved diabetic macular edema, but the vision is excellent at 20/16. And this is really a very common clinical scenario. In fact, even in the ETDRS, 40% of eyes in that study with center-involved DME had good vision. So this brings up the question, what is the optimal management for eyes with center-involved DME and visual acuity of 20/25 or better? Well, we addressed this question in Protocol V by enrolling a cohort of adults with diabetes who had center-involved DME on OCT and visual acuity letter score of 20/25 or better with no or minimal prior treatment for diabetic macular edema. We randomized these eyes to 3 potential treatment algorithms, the first involving immediate aflibercept or anti-VEGF treatment, the second 2 involving laser or observation at baseline with aflibercept only given during follow-up if the visual acuity worsened. And our primary outcome was the proportion of eyes that lost 5 or more letters of vision at 2 years. Important secondary outcomes included mean change in vision and CST from baseline at 1 and 2 years. How did we follow these eyes that began in the laser and observation groups? Well, we took the eyes and they gave their assigned treatment at baseline, and then we followed them at 2 months. And we asked the question, did the visual acuity get worse? We used as a threshold for this a loss of 10 or more letters at any visit or 5 to 9 letters at 2 consecutive visits. If the answer was yes, they had lost vision, we initiated the DRCR Retina Network anti-VEGF or DME regimen. That was the same as we used in Protocol T. If not, we asked if there was anatomic worsening. We said, is the OCT central subfield worse, using a threshold of 10% or more increase, or retinal thickness centrally that was greater than 400 microns on time domain equivalent? If the answer to that was yes, we didn't initiate anti-VEGF, but we did decrease the follow-up interval to a minimum of 1 month. If no, we doubled the follow-up interval to a maximum of 4 months. The 702 eyes enrolled in the study were evenly distributed across the treatment groups with equivalent visual acuity scores that were equivalent to Snellen vision of 20/20 and OCT central subfield thickness in the low 300s. So here's our primary results. We saw no significant differences in 5 or more letter vision loss at 2 years, and the aflibercept, laser, and observation groups had rates of 5 or more letter vision loss of 16, 17, and 19% respectively. We also saw similar rates of 10 or more letter vision loss across the groups at 2 years, with 9% in the aflibercept group and 7% in the laser and observation groups. When we looked at eyes that met a threshold of achieving vision of 20/20 or better at 2 years, we saw that the aflibercept-treated eyes had higher rates of 20/20 or more vision. 77% of them achieved this goal, whereas only 66% of the eyes in the observation group had 20/20 or more vision, and this was a statistically significant difference. And yet, when we looked at overall letter score equivalent to 20/25 or better, the rates of eyes with 20/25 or better vision were very similar across the groups, about 84 to 86%. What about mean letter vision score? Well, at 2 years, mean vision in all 3 groups was 20/20. And when you looked at mean change in vision score from baseline, there was statistical superiority of aflibercept over initial laser or initial observation at 1 year, but this difference was diminished and was no longer statistically significant at 2 years. We performed an exploratory analysis looking at area under the curve for mean change in average vision letter score over 2 years. This did favor the aflibercept over the observation and laser groups, but we think that the mean change in letter score of about 1.5 to 2 letters is probably not too clinically significant. So what about anatomy? Well, the anatomy mirrored the visual acuity outcomes. At 1 year, we saw that there was more thinning in the aflibercept-treated group than in the laser or observation-treated groups. But at 2 years, this difference disappeared, and the outcomes were very similar. In terms of DME treatment, here you see the time to first aflibercept injection across the laser and observation groups. And we saw that on average, there were slower rates to time to first aflibercept injection in the laser than the observation group. This was statistically significant. And you'll notice that only about a quarter of the laser group and a third of the observation group got aflibercept injection over 2 years. So while we did have some eyes where injections were given, and here's an example of an eye that had vision worsening between baseline and 1 year, got injections, and had improvement in vision to 20/20 at 2 years, and some resolution of the DME, actually the majority of eyes did not receive aflibercept injection for vision worsening. Here's an example of an eye where the DME resolved spontaneously, and at 2 years the vision was actually 20/12. Aflibercept treatment for DME in eyes that got any injections were actually very similar across the group. So once you started getting aflibercept, on average, each group of eyes got about 8 injections over the course of the study. We didn't see a significant difference in ocular adverse events or a difference in APTC thromboembolic events that occurred in our patients. And so in summary, in our patients with center-involved DME and good visual acuity, we did not see differences in rates of 1 or more lines of vision loss at 2 years among eyes that initiated management with aflibercept, laser, or observation. All 3 of these management strategies resulted in mean vision at 2 years of 20/20. And although the proportion of eyes that were 20/20 or better were significantly greater with aflibercept than observation, the proportion of eyes that were 20/25 or better were very similar in each group. The majority of eyes in the laser and observation groups didn't receive any aflibercept during the study. Really important points to note are that this study compared 3 different management strategies. These were not monotherapies, and we followed these eyes very carefully. Aflibercept was initiated in both the laser and observation groups if the vision decreased by 1 line at 2 consecutive visits or 2 or more lines at 1 visit. Changes on the OCT without vision loss did not trigger aflibercept initiation. Our primary outcome was loss of 5 or more letters. We thought that this was likely to be clinically relevant in eyes with good vision and unlikely to be due to chance variation. And so we conclude from the study that among eyes with center-involved DME and good vision, there was no significant difference in vision loss at 2 years in eyes that were initially managed with aflibercept or with laser or observation that were given aflibercept only if vision worsened. Given the costs and risks associated with interventions, observation without treatment, unless vision worsens, may be a reasonable strategy for these eyes. This paper was published in the Journal of the American Medical Association this summer, and the Protocol V slide set is available freely at www.drcr.net. Thank you very much.